It's my pleasure to introduce you the next speaker, Francesco Maisano. He's an Italian surgeon that moved to Switzerland, and we miss him very much. And he will talk about percutaneous repair of the tricuspid valve on the horizon.
Okay, thank you for missing me. Anyhow, I'm very happy to be in Switzerland, and I'm also very happy to share with you some very preliminary data. I want really to start telling you that this is welcome to the dark side of the moon. Dark side of the moon because we have been talking about tricuspid valve for many years, like the forgotten valve. I think in this community is not forgotten at all. But generally speaking, tricuspid valve has been less focus of treatment, and today there is a huge interest, particularly in transcatheter interventions. And the reason is that it is a difficult situation when a patient comes with, specifically with isolated tricuspid regurgitation, particularly when these patients come after failed surgery, and not to discuss about the situation of patients with right-sided anomalies. So, in principle, these patients are difficult to handle. It is probably a subgroup of patients who have also a special trend towards a worse prognosis, whether this is due to the tricuspid insufficiency or whether tricuspid insufficiency is just a signal, a factor of a higher level of disease, of a more advanced level of disease. This is still a matter of concern. Anyhow, in heart failure, in valve disease, it has been shown that the presence of tricuspid regurgitation is a risk factor for shorter survival. Obviously, there are several conditions, and I am not coming here to propose transcatheter procedures for anomalies, because I think this is even not in the pipeline at the moment. We talk about secondary tricuspid regurgitation, which is a condition where the tricuspid regurgitation happens initially for some degree of annular dilatation, and then progressively becomes a right ventricular dilatation deformation, and at the very end stage is a combination of the two conditions creating this regurgitation. In this condition, the guidelines for tricuspid surgery are somehow trying to propose reoperation in case of preserved right ventricular function, which would be also difficult to define, specifically in this particular condition, and in absence of severe pulmonary hypertension. So again, we're talking about conditions that very often are not fulfilled in your own practice of grown-up congenital adults. Anyhow, and here is the dark side of the moon. There are a number of techniques in surgery to try to repair these valves. And when you have many techniques, it means that more or less none of them is really working well. And all of these techniques have already a transcatheter device which is somehow philosophically connected. We can do annular repair, we can do cinching between the chamber, the anterior wall of the ventricle and the septal wall of the atrium. We can join the leaflets, we can somehow reproduce leaflet augmentation implanting spacers through the tricuspid valve, and there is already some experience in tricuspid replacement. I have personal experience in 3 of these procedures, and I mean, I play this always. I brought this slide also here because I'm sure that you know the answer. Which one of the two is the tricuspid valve? Basically, tricuspid valve is on the right. They are pretty similar from an anatomical perspective. The tricuspid valve has a mural leaflet, cords, papillary muscles, but as you know, there are some differences. And again, in your practice, you know the main difference, for instance, not having a LV outflow tract combination of the anterior leaflet with a septum. In this case, there is a infundibulum. So, for instance, in theory, implanting a valve in the tricuspid space, it is potentially feasible, probably more feasible than in a mitral position, where the main issue of transcatheter mitral implantation is LVOT obstruction. Here, we don't have a problem of LVOT obstruction. On the other hand, the valve is very large, so there is a technology problem. So there are similarities and dissimilarities, and these things generate a problem that most of the mitral devices which have been developed to treat mitral regurgitations have been applied also in the tricuspid space, but not all of them function. Another challenge for the development of this field is the guiding imaging. So, as you know, transcatheter valve interventions are mainly dependent on appropriate imaging for patient selection, imaging guidance to the procedure, and last but not least, for evaluation of outcomes. So when we started doing the first cases, we were lost in space. And so we tried to generate a common nomenclature for the procedure itself. It looks strange that we still have to discuss about nomenclature, but in a procedure, when you say superior for interventional cardiology, superior means going towards the apex, towards the head of the patient, while for the echocardiography, superior means away from the tricuspid annulus. Anterior, septal, how to name the commissures have been all a discussion. So we had to set up this common ground between the operators and the echocardiographers which were guiding the procedures. And in this process, I think also fusion imaging has been, for the first time in my experience, somehow something which would add some advantages in this communication. So we were able to really understand each other. So among the various procedures, the one that has reached the highest experience, and I don't know the exact number at the moment, I was 2 months ago, it was about 300 cases worldwide. So probably now we are around 400 cases of mitral clip done worldwide. Why this is booming? Not because it's the best solution, but for sure because it is a drive-through options. A lot of cases, you have a patient with mitral and tricuspid insufficiency. You treat in the mitral, just pull back. As you go back from the septum, you can face the tricuspid valve and you can try. Actually, this is the way we have been starting our procedures. And obviously, we can discuss whether this is appropriate or not, but it has been pretty instrumental to develop the first tricuspid repair procedures. Now, can we adapt the mitral clip to tricuspid? Also in this case, there have been some challenges. First challenge was the approach. The first approaches were done through the jugular vein because of less curves, but actually it was very difficult for logistics to work from the head of the patient. So at this moment, all centers are working from the groin, with some modification in the delivery system. The delivery system has not been designed for the tricuspid approach. There is no transeptal puncture needed, and this is somehow an advantage for someone, maybe, but it is a big disadvantage because for the tricuspid approach, you don't have a stabilizing structure. So this delivery system is basically floating in free space, and the initial challenge has been always that the delivery system was bringing the clip too deep into the right ventricle and was not enough space to pull back and grasp the leaflets. This is one example that shows this procedure. Again, you can see pretty well the clip in this particular case. Not all patients have a good TE window, but as you can see, the images are not as crystal clear as for the mitral space. The main issue is that imaging, particularly the leaflet of the tricuspid valve, is not as good as for the mitral. tricuspid is more difficult to see. The second challenge is that the leaflets usually in these patients are very far away because there is annual dilatation. So grasping the leaflets in the middle of the valve is usually not possible. And therefore, mitral clip in tricuspid means that you can put clips in the commissures. You can close one or two commissures and try to reduce MR that originates from commissures. This is a little bit not really directly what would be ideal. There will be a tricuspid mitral clip produced, which will have larger legs to grasp leaflets, but at the moment it's just, I would say, truly palliation here. Anyhow, there is some data that we generated in a multi-center study that shows, anyhow, that in about 60% of patients you get some degrees of reduction of tricuspid regurgitation. Very promising technology is annuloplasty. This cardioband is a device which is being developed for annuloplasty on the mitral annulus, and a mirror design for tricuspid has been developed to allow the same approach in the tricuspid position. This device is basically implanted with multiple anchors, again under echo and fluoro guidance. The main challenge for this procedure, besides imaging, which probably is not that complicated because the annulus is well visible by echo, but the main challenge here is the presence of the right coronary artery, which is basically surrounding the full anterior and posterior annulus, and therefore the risk of damaging the coronary is possible with these anchors, which are 4 or 6 millimeter long, and they have to be implanted every 8 millimeter to 1 centimeter all around the annulus, from the anteroseptal commissure towards the posteroseptal or beyond. And after this ring has been implanted, you can cinch the annulus and obtain reduction of the annular dimensions by 40–50%. So now I don't have the time to show the whole procedure here, but you could see here on beating heart conditions a immediate reduction of TR. In this particular case, actually an abolition of TR. Let's waste another 2–3 minutes, because it's for me as a surgeon, I say always when I see this is an epiphany. It's something completely new. I've never seen in my eyes disappearing malcoaptation by acting directly in a physiological condition. So this is at the end there will be no MR. This is another annuloplasty device which is designed to placate the annulus. In principle, you can also in this case make a full circumferential plication of the reduction of the annulus, but this is basically reproducing the posterior plication annuloplasty, K annuloplasty, bicuspidalization annuloplasty, whatever you want to call it. And this is Trialign is a device originally designed for mitral and has been applied in tricuspid with some reduction of TR. This is one of the big challenges, how to define reduction and what is a reasonable degree of reduction, which is improving symptoms in these particular complicated patients. Anyhow, the data has been just published from a multi-center study, including centers in Europe and US, and it shows some efficacy in terms of reduction of TR with incredible improvement of symptoms, although not all patients have really achieved amazing good results. Another technology is based on reducing the septal anterior dimension of the annulus. This device has been in an early feasibility trial in Europe, showing some interesting features. This is a very simple device to implant, and it reduces TR again in about 60% of patients, but it has had a number of detachments because there is one single anchoring point. So therefore, it is undergoing at the moment a redesign for the anchoring part, and you can see with new designs you can achieve a very important reduction of the septal anterior dimension and abolition of TR in animal models. Another alternative is to, instead of trying to put the leaflets together, put a plug in between the leaflets, or let's say a spacer. This technology here in Switzerland, Bern is leading this field by implanting this device, which is working in a different way. Imagine a paisley lid with a balloon, and this is basically filling the gap between the leaflets. Also, this technology has been shown to reduce TR in a majority of patients and improve in quality of life. I will use my last 23 seconds before the cow comes back to show you replacement is also feasible. It's been done in 2 patients at the moment with more or less a transcatheter approach with a specific valve which is very large. But most of the mitral devices will not be possible to implant in the tricuspid position because of the annular size. So what we can do in some patients, not many, and probably what you can think about of your patients which are very complex anatomies, you may think in some patients for palliation, heterotopic implantation of valves in the inferior and superior vena cava. This has been done a bit aggressively in Berlin, in Charité. There are a lot of open questions. Anyhow, these patients may be stabilized for some time, and I think it is an interesting approach whenever feasible. It's not always so easy to do, also because in this case the vein can be very large. Valve in valve, valve in ring, I don't talk about it because I think it's standard practice. And I will conclude with this slide that shows that there is a registry collecting all this data. The registry shows there is about 50 to 60% success rate in terms of reducing TR. But really, the main issue is that we are still learning. We really don't know much about tricuspid. We have a number of devices which are treating a disease that we don't know. We don't know how this works. We don't know whether this works, whether this is needed. We don't know anything. So welcome to the dark side of the moon, and thanks God we have a lot to do to learn more. Thank you.
Questions from the audience?
Peter Eriksson, Sweden. It's obviously a challenge to repair the tricuspid valve. It's not percutaneous, not now, but what do you think, what's your opinion on when you try to do a repair surgically on the tricuspid valve to add a volume reduction by doing a bidirectional gland? What's the role of
So I have done this only once in my whole career, and again, I'm not, I'm in the wrong room here. I'm not expert with the grown-up congenital cardiology, so don't overestimate my answer. So I think it is obviously having some preload control is important. And I think in some patients with end-stage right ventricular failure, or in patients who have anyhow a strong secondary condition, combine these things could be, in some patients, talking with you guys, that you tell us what to do, because I love the discussions behind grown-up congenital cardiology patients can be an option. But in principle, this is restricted to a specific population. In my opinion, the large part of the population with tricuspid insufficiency is basically patients with functional MR, and in most of my practice, tricuspid regurgitation should not happen. We need to prevent this to happen. So I think we need to be a little bit more aggressive in treating, particularly surgically, in treating early stage of tricuspid regurgitation so that it doesn't progress.
I think that this is the crucial point. We are speaking about good patients that are a specific population. If you think about which kind of our patients had tricuspid regurgitation, so we have 4 groups: Epstein anomalies, and I don't think that this procedure have a future for Epstein anomaly. There is Glenn proceeded as a future. All my abstract anomaly, I had a Glenn approach for this procedure. The second is systemic tricuspid valve, like in a correct transposition or after master ascending. Once again, I don't know which space we will have for this procedure.
It has been done.
Third group are surgically damaged tricuspid valve by previous operation, like tetralogy of Fallot. And usually these are the most difficult patients to repair tricuspid valve. Usually we have a lack of a septal leaflet, usually fibrotic related to the patch of the VSD and so and so. And even for surgery, it's very difficult to repair these patients, this tricuspid valve. And the fourth group are functional tricuspid regurgitation, but not related to the mitral valve, related to the pulmonary problems. So patient with pulmonary regurgitation or branch stenosis and so and so. And obviously, if you don't treat the first reason of the tricuspid valve regurgitation, functional regurgitation, you will never solve the problem. So it's interesting, absolutely. We have every time to be open to the something happening in the technologies, but we have to be quite in peace with this part.
I think what you mentioned is fundamental. So tricuspid regurgitation is the end stage, in most occasions, the end stage of a process, and we should try our best to avoid that. I'm not sure that repairing the valve is a solution at the end. And I don't know whether Epstein, maybe, you know, we can think about spacer like this this Forma device could be in theory applied in that condition. And you probably forgot one category, which is lead pacemaker patients who have TR. This is also an area where maybe percutaneous procedures may have a role. You know, when I have been operating, we cannot give you guidelines because this is a work in progress. But in surgery, when I have a patient with tricuspid regurgitation because of a lead, which is pushing on the leaflet, what I've done always have been to englobate in this lead instead of trying to detach it. I've been englobating the lead in a commissure, close the commissure, and do an angioplasty. We can do this with a clip. We can englobate this. We can eliminate this this lead from this mechanism of regurgitation. I have done a couple of cases like this, but again, keep the mind open. There are solutions, but this is really, we are talking about 1 year experience in many centers, and average experience in each center is 5 to 20 patients. So,
and I
still
think that
learning.
the most important message is that the impact of tricuspid regurgitation in our patient is very relevant, very important. And if our patient have to send to surgery for pulmonary valve implantation or something else with tricuspid regurgitation, tricuspid valve must be treated. Will never improve otherwise.
I just would like to stick to that point, Alessandro. We have done now an analysis of our patients for percutaneous pulmonary valve implantation with moderate to severe tricuspid regurgitation. And I would stress this also because I think it's secondary. You know, the tricuspid regurgitation is, well, if you can get rid of the obstruction in the right ventricular outflow tract, the right ventricles in volume, we did a matched pair analysis, they improved, they went smaller. So if you have a lot of things, and our surgeons say the same as you say, that in these patients it's very difficult to fix the valve. It's very difficult. So they were very happy if we could fix the right ventricular outflow, and by this, in some of our patients, even the tricuspid regurgitation got less. Some it stayed, although, because there was severe morphological differences. But in general, the patients were better in the right ventricular and diastolic volume, and also in the exercise capacity.
Yes, but now with the new devices for transcatheter procedure, you are right. But until yesterday, 90% of your patients that you put a transcatheter valve in the pulmonary position are patients with an obstruction, not a regurgitation. So this patient, the right ventricle, is hypertrophic, not dilated. So it's a big difference between this type of right ventricle related to pulmonary obstruction, like a conduit obstruction, and patient with a free pulmonary regurgitation for 30 years.